Sulochana, Assistant Professor in School of Public Health from Jesus Medical College, Mysuru, Karnataka, India. I'm truly honored to be presenting research at this esteemed international webinar on global health and medicine. So today I'll be presenting study titled Effect of Screen Time and Physical Activity on Sleep Quality Among Adolescents. Is it moving now?
Yes. Please go ahead, doctor.
Yes, I'll be presenting in this mode only. Is it okay?
Yes, please go ahead,
Thank you
doctor.
so much.
Thank you very much.
So, yeah, coming to the introduction, adolescent defined as the age group between 10 to 19, and it's a crucial window for building lifelong health foundation. And India is the home of the largest adolescent population in the world, over 253 million adolescents, making up a substantial part of our demographic dividend. And however, this dynamic group is increasingly influenced by modifiable lifestyle behaviors, especially physical activity, screen time, and sleep habits, which is impacting our adolescent health. So the background is the World Health Organization recommends that adolescents should engage in at least 60 minutes of moderate to vigorous physical activity per day. But however, in today's digital age, there has been a sharp increase in screen usage from smartphone to tablets and gaming, which has contributed to a rise in sedentary behavior. This change in lifestyle is not without consequences. We know that researchers consistently show that excessive screen time is linked to various adverse health outcomes. Could be physical, mental, and etc. So poor sleep is now increasingly recognized as a key issue. So the objective of the study is to assess sleep quality among adolescents. And the second is to determine the sleep quality association with the screen time and the physical activity. The methodology, it's a cross-sectional study, and the adolescent, both boys and girls, from pre-university colleges of Mysuru city, Karnataka. And the sample size is 370. And the tools which we use to collect the data about sleep quality is Pittsburgh Sleep Quality Index, and about sedentary activity we used adolescent sedentary activity questionnaire. And to know about their physical activity, we used the WHO's Global Physical Activity Questionnaire, and the data was collected in person, face-to-face. Coming to the result, we had our population from 13 to 18 years of age group, but most of them, around 73.2 were belonging to the age group of 16 to 18. And 57.7 were male, and most of them were like 95.9% of them belong to Hindu religion. And coming to the socioeconomic status, they belong to upper middle class, 34% of them. And family, 70.7% belong to nuclear family. And BMI, we can see that 46.3 did not have normal BMI. Only around 50% had normal. So that around 50% of them are overweight or obese. And when we check for the sleep quality, we got to know that around 22.1% of the students or our participants had poor sleep. And we can see that 53.6% had daytime dysfunction and disturbance due to factors like waking up in the night, using the bathrooms, or breathing difficulties, snoring, temperature discomfort, bad dreams, pain, or other reasons. And 47.3% participant had a sleep latency of less than 15 minutes. And only 62.1% slept 6 to 7 hours per day. Coming to the physical activity, 86.8% of the participants walked or cycled to go to college. It's like we used bicycle for the travel purpose. And during leisure time, 57.7% of participants were vigorously active, and 80.4% were moderately active. So physical activity done during leisure and travel activity, like bicycle or using going by walk, are significantly associated with improved sleep quality among adolescents. When we come to screen time, it is higher on the weekends. Participants used screens. It may be tabs, desktops, or phones, gadgets. That was higher on the weekends. Too much screen time, especially for the entertainment on the weekends, and studying or social activities on weekdays can disturb the sleep, and it is statistically significant in this study. And when we see the association of sleep quality with screen and sleep quality with the physical activity, we can see that weekend there are small screen use which are statistically significant, and the weekdays they had educational and social screen time which were significantly linked with poorer sleep quality. And when coming to the physical activity, leisure time, when they had leisure time, they had vigorous and moderate physical activity, which showed a strong association with better sleep. Travel related activity also showed significantly linked between better sleep. So, while work and school activity, there was no significant effect. We can say that screen time should be reduced and physical activity should be increased among students or adolescent. And when we see the screen time and sleep quality among adolescent, just a global snapshot where we can see that in developed and developing and underdeveloped, it is same screen time. It affects adolescent health. There is poorer sleep, which in fact later, in fact, the consequences are like related to health directly, and they're very much significant statistically and clinically significant. So in developed countries, we can see that 75% of the teens use screens before bed, which reduces their sleep quality. And in the developing countries, we can see that screens used less than 2 hours per day. It is more likely to report poorer sleep. And 70% of the adolescents have poor sleep quality. And evening phone use cuts sleeps by 45 minutes. This is also evident. This is also seen. And underdeveloped countries, also like Nigeria and other countries, there also 60% of the teens sleeps less than 7 hours per night. And smartphone use is rising. And similar with the sleep issues. Coming to the conclusion of the study, poor sleep quality was observed in over one-fifth of our adolescent. Higher screen time, especially for recreation on weekends, and in weekdays it is for social and educational use, was significantly linked with poor sleep. In contrast, engaging in physical activity during leisure and travel was strongly associated with better sleep quality. So promoting healthy digital habits and encouraging daily physical activity can significantly enhance sleep and overall well-being among adolescents. We have to limit screen time before bed also. Thank you so much for giving me an opportunity to speak in this international webinar. Um,
Good afternoon, dear colleagues. We would like to present to your attention a report on the topic of WHIM syndrome. Bone marrow examination is a key to diagnosis. WHIM syndrome is an extremely rare combined immunodeficiency with symptom complex of which is reflected in its name: warts, hypogammaglobulinemia, infection, smiley-cathexis. The prevalence of WHIM syndrome is not reliably known. According to the published data of Busan-Cohen et al., the incidence is approximately 0.23 cases per 1 million newborns. Just over 100 cases have been described in the literature. Most cases of WHIM syndrome are caused by autosomal dominant activating mutations with gain of function in the gene encoding the chemical receptor of the same name, CXCR4, which is widely expressed on leukocytes. Mutations in the CXCR4 gene are located at the C-terminus of a receptor, which leads to prolongation of a receptor's exposure time on the cell surface and enhanced receptor activity. As a result, the release of mature neutrophils and lymphocytes from a bone marrow into the blood is impaired. Warts. Skin warts are more likely to appear in patients of 10 to 20 years of age in their arms, legs, chest, and face, and may be resistant to various treatments. In adults, anogenital warts can progress to acute condylomas and neoplasia. The pathogenesis of warts is based on infections with the human papillomavirus. High susceptibility of patients to HPV is due to the anti-lymphopenia. Hypogammaglobulinemia. Patients with WHIM syndrome have a reduced ability to produce a humoral immune response, which is associated with low levels of circulating B cells. Hypogammaglobulinemia may involve one or more classes of immunoglobulins. The frequency and severity of hypogammaglobulinemia is variable, with some patients having normal immunoglobulin levels and others at all below normal. Infections. The common infections are recurrent otitis media and otitis externa, common, resulting in rupture of a tympanic membrane and scarring, acute and chronic sinusitis, recurrent lung infection cause damage, and dilation of the bronchi, leading to bronchiectasis, frequent skin and soft tissue infections, gingivitis, periodontitis, and early tooth loss. Myelocathexis. Myelocathexis, from Greek retention, is the retention and apoptosis of mature neutrophils in the bone marrow, resulting in neutropenia and characterized by degenerative changes in mature neutrophils. The term was first used by Zolze in 1964 to describe the phenomenon of a lack of neutrophil release from the bone marrow in patients with chronic neutropenia. Myelocathexis is one of the main criteria for diagnosing WHIM syndrome. Bone marrow is hypocellular, the content of mature neutrophil is increased, shift to the right. Segmented neutrophils have pronounced degenerative changes. Cytologic features of mature neutrophils at the WHIM syndrome, its pyknosis of nucleus. Thin and long chromatin junctions between segments. Abundant cytoplasmic localization. There may also be hypersegmented neutrophils. It's now known that this morphology is typical of cells undergoing apoptosis. There is also localization in eosinophils. We would like to present the data on the patients with WHIM syndrome treated in our clinic during the years from 2000 to 2024. In the study group, the patients' distribution by sex, male and female, had the ratio of 6:5. The age at the time of diagnosis ranged from 7 months to 39 years old. They analyzed the indicators of clinical blood tests, serum immunoglobulin content of blood, and the results of bone marrow punction before the start of specific therapy. In clinical blood tests, leukopenia and neutropenia were detected in all patients. Lymphopenia was established in all patients. Minor anemia was detected in 3 out of 11 patients. Thrombocytopenia wasn't detected in any patient at the time of diagnosing. The age of patients at the time of neutropenia detection ranged from 3 days to 10 years. The age at the time of lymphopenia detection ranged from 3 months to 16 years. Thus, the delay in diagnosing WHIM syndrome from the time of neutropenia detection ranged from 7 months to 29 years. Hypogammaglobulinemia was noted in 8 out of 11 patients, with age ranges from 3 months to 16 years. 3 patients, P2, P4, and P10, didn't have decreased serum immunoglobulins at the time of the study. In addition, 1 patient, P4, had a pronounced increase in immunoglobulins A and M with normal immunoglobulin G values at the time of the study. Various infectious diseases were noted in clinical pictures of all patients. Pneumonia was the most frequent, observed with 9 out of 11 patients. Recurrent otitis media was observed in 7 out of 11 patients. Bronchitis and sinusitis occurred with equal frequency in 4 out of 11 patients. Furunculosis in 5 out of 11 patients. As a consequence of recurrent sinopulmonary infections, bronchiectasis developed in 2 out of 11 patients. As to non-infectious diseases, Various developmental abnormalities were present in the clinical picture. Cardiovascular system abnormalities in 8 out of 11 patients, genitourinary system abnormalities in 7 out of 11 patients. 5 out of 11 patients had various abnormalities in mental and psychiatric development. Warts were registered in 2 patients. Intradermal melanocytic nevi were noted in 1 patient. 1 patient had growth retardation bone system pathology, valgus deformity of the new joints, flat valgus deformity of the feet, and idiopathic arthritis. The most frequent of all of the CXCR4 mutation identified in patients was this. Position substitution already described in literature. It was observed in 7 out of 11 patients. This mutation haven't been described in literature yet. However, based on the totality of data, we classified them as pathogenic. Bone marrow puncture was performed in 10 out of 11 patients. Bone marrow hematopoiesis was assessed using light optical microscopy in smear stained according to the Pappenheim-Krukov method. Increased cellularity of the bone marrow was noted in 5 out of 11 patients. The rest had normal or described cellularity. Neutrophil count remained within the reference values in 3 out of 10 patients. Negative tendency was not in 2 patients, positive in 5 patients. The predominance of mature forms of neutrophil rightward shift was observed in 6 patients. In all cases, mature neutrophils showed vocalization of cytoplasm from 2.5 to 19% of cells. Pyknotically altered nuclei were observed in 0.5 to 3% of cells. Long chromatin junction between segments in 2 to 9% of cells. Hypersegmentation was observed in 4 out of 11 patients. Vocalization of the cytoplasm of eosinophil cells was also noted in all patients. Monocytes and lymphocytes didn't demonstrate morphological particularities. As you can see on this table, the neutrophils and eosinophils of patients with WHIM syndrome have the same specific morphological features. The particular cell morphology should be an alarming factor for the laboratory specialist. Myelocathexis is the key to diagnosing WHIM syndrome. Myelocathexis is the most informative sign of WHIM syndrome. Specific morphological abnormalities of neutrophils, namely pyknotically altered nuclei, long chromatin junction between segments, and cytoplasmic vocalization, as well as vocalization of eosinophil cells and bone marrow, help to distinguish myelocathexis from most other forms of neutropenia. However, early diagnosing may be difficult due to the following reasons. Firstly, myelocathexis can only be detected by bone marrow examination. Peripheral blood smears are not informative. The second reason is its rare occurrence. And the last one is the lack of awareness about the diseases among laboratory diagnostic specialists. In conclusion, I would like to stress that WHIM syndrome is an extremely rare primary immunodeficiency. Diagnosing is often delayed and may take several years due to rare occurrence, although awareness of physician about these diseases and absence of tetrad of possible manifestation in most patients. Detection of the manifestations of myelocathexis is the most informative sign of WHIM syndrome. Is difficult because it requires bone marrow puncture. Also, when examining bone marrow aspirate, morphologic features of mature neutrophils and eosinophils may go unnoticed by the laboratory specialists. The alertness of diagnosticians, regardless of their specialization, will expedite the diagnosing of this rare disease. Thank you for your attention.
By women who inject Nyaope, residing in City of Tshwane Municipality in Gauteng Province. I'm Dr. Tinabuyo Robert Netangayen. The background: Nyaope injecting practice brought the field of human immunodeficiency virus, HIV prevention, and substance use disorder together. It is a complex and require multidisciplinary approach. Women who use drugs face individual, social, and structural factors that fuel their vulnerability to contract HIV and other blood-borne infections. Women who inject drugs are subpopulation that is neglected from HIV prevention and substance use drugs treatment intervention and are hardly the subject of survey. In order to fully address the HIV epidemic among women who inject drugs, it is imperative that they become part of the process of finding solution. Nyaope injecting practice has brought field of human immunodeficiency virus, HIV services, and substance use disorder treatment together. Nyaope is a drug preferred by many drug users in township, especially in Gauteng 1. It has been reported that the use of Nyaope has increased in recent years, mainly among young African and mixed race male in South Africa. Nyaope is a novel, fashionable drug that is normally used in many townships in South Africa. The full makeup of Nyaope is not known, even though most researchers concur that heroin is the main component, with rumors of the inclusion of antiretroviral having been documented. Nyaope is called a different names in different areas. In Gauteng Township, such as Soshanguve, Mamelodi, Soweto, it is called Nyaope, while in KwaZulu-Natal Township, such as Umlazi, Kwamashu, Inanda, is called Wunga. The practice of Nyaope injecting needs to be researched and call for integrative substance use disorder treatment and HIV services for people who inject drugs in South Africa are limited and are primarily provided by civil society organizations. Publicly funded SUD treatment services are almost exclusively abstinence-based. Despite the upsurge in heroin use and increase in injecting use, there is no established framework to deal with the public health crisis that predictably follows the increased dependent use of unregulated opioids. Nyaope is a multifaceted challenge and in addition is caused by a variety of factors. Nyaope addiction needs to be a multifaceted approach. It poses unique challenges in different communities. The challenges cannot be addressed without engaging the users to shed light on their challenges, coping resources, experiences, risk and needs and hope. Reducing HIV incidents amongst women who inject Nyaope can only be achieved through HIV prevention and treatment. Women who inject drugs are subpopulation that is neglected from HIV prevention and SUD treatment intervention and is hardly the subject of survey. To fully address the HIV epidemic among women who inject Nyaope, they must be part of the process of finding solution. Women who inject drugs are more likely to participate in drugs and sexual risks that makes who inject drugs to severe discrimination and cultural stigmatization. Women who ingest drugs tend to be dependent on drugs faster than their male counterparts, inject more frequently per day, have intimate partners who inject, contract and die from HIV/AIDS, and have severe combined risk. This is partly because most of them engage in sex work to raise money for drugs. Women who inject drugs engage in unprotected sex with their clients as well as their ultimate partners and have higher rates of sexual transmitted infection. They are also at risk of experiencing sexual violence and incarceration. There is lack of programs that integrate SUD and HIV services for people who inject drugs in South Africa. Regardless of the acknowledgement of the effects of the drug use on HIV transmission, there are inadequate HIV harm reduction services in South Africa. There is only one harm reduction program that is funded by the South African government within the whole of South Africa. Community-oriented substance use program, in brackets COSAP, which is implemented by the University of Pretoria, Department of Family Medicine, and funded by the City of Tshwane Municipality, is the first publicly funded community-based program to respond to the use of unregulated drugs in South Africa. Based on the connection between risk behavior, drug use, it can be justified that strengthening effort to offer integrated HIV harm reduction and SUD treatment services should be prioritized. Although the drafting of SA Third National Drug Master Plan gave eminence to the necessity of addressing drug abuse as part of the comprehensive HIV prevention efforts, program targeting people who use drugs with a sole purpose of addressing drug use and sexual risk behavior in South Africa are scarce. South Africa first used needle syringe program in 2014 in Cape Town, extended to Durban and Pretoria in 2015. The study aimed to investigate strategies to mitigate or cap HIV incidence among women who inject Nyaope in residing in the city of Tshwane. The method, the study design, qualitative methods were used to explore and describe strategies that could be used to cap or mitigate HIV incidence among women who inject Nyaope. The research was conducted within the COSAP sites across City of Tshwane. By mid-2019, there were 17 functional and viable sites available to clients in City of Tshwane. 12 included drop-in centers that provided access to ablution facilities, nutrition, computers, and other psychology safe space where to socialize. Community-oriented, the COSAP was considered more suitable as it is harm reduction-based organization that offered opiate substance therapy and needle exchange program. The study was conducted on women between age of 18 and above who reside in City of Tshwane municipalities. The researchers sampled 24 participants from the population, 15 who were currently injecting Nyaope and 9 with a history of injecting Nyaope were interviewed. Inclusion and exclusion criteria were followed during the sampling process. Purposive sampling method was used to recruit participants from COSAP. The 6 months was considered adequate to exclude participants who might have enough living experience as Nyaope injectors. The researcher understood the female Nyaope injectors are a hidden population, and if a 1 year plus of injecting experience is required, the researcher might struggle to find suitable participants. Data collection, after permission from the COSAP, and the researcher liaised with the workers and the data collection for the data collection. All the interviews were audio recorded and interviews were kept safe to protect their information and maintain confidentialities. The researcher did not interview 15 recovered injectors because of data saturation. The research reached data saturation after the researcher interviewed 24 research participants. Saturation was reached after the 19th interview. Data analysis follow the phases of thematic, 6 phases identified by Bryan and Clark, of which phase 1 is the researcher acquainted himself with the data. Phase 2, the researcher generated the initial data codes. Phase 3, the researcher searched for themes. Phase 4, the researcher reviewed themes. Phase 5, the researcher defined and named the themes. And phase 6, the researcher produced the report. Ethical consideration. The article is part of the master dissertation of exploring the experience of female Nyaope injectors residing in the City of Tshwane. It was approved by the Research Ethics Committee of the University of South Africa. The results, biographical characteristics. Participants were between age of 20 and 35 years old. 15 participants were current injectors and 9 were recovered injectors. Key findings. The key questions of this study was, what are the strategies to mitigate or curb HIV incidence among women who inject Nyaope residing in the City of Tshwane? 3 main themes and 7 sub-themes of the data were created. The key finding, pre-exposure to prophylaxis. Participants appreciated the value of PrEP medication as having the potential to curb HIV incidence among women who inject Nyaope. It is reflected on the narrative of participants that there is medical treatment available for people who are negative and have a high risk in contracting HIV, but they lack knowledge of the treatment. Human immunodeficiency virus counseling and testing. Participants shared that making HIV counseling and testing available to women who inject Nyaope can curb HIV incidence among women who inject Nyaope. Human immunodeficiency and counseling. Economic intervention, employment opportunity. Participants are of the view that employment will influence their chances of participating in sex, which increases the likelihood to contract HIV infection, and they will further stop to depend on other people. The discussions. The results of these empirical studies indicate that HIV amongst women who inject Nyaope can be kept by multiple interventions. The findings highlight health, economic, and educational intervention can be utilized to curb HIV incidence among women who inject Nyaope. Programs that offer disinfected injecting equipment are highly effective in decreasing transmission of HIV and other blood-borne infection. Needle exchange program has a lot of potential to address needle sharing among women who inject Nyaope when implemented. The needle exchange program has been shown to decrease risky behavior to provide a critical link in case of PWID, who may receive all or most of their services through their national strategic plan. Poor social economic status can act as an obstacle to educational prospect, the opportunity to approach healthcare, employment generating, or a conducive environment for HIV incidents. The establishment of locally based support groups was indicated to have a potential to curb HIV amongst women who inject Nyaope. Recommendation for this study. Findings of this study demonstrate that HIV incidence among women who inject can be kept or mitigated. It is further identified harm reduction programs as having the potential to address the risky behavior of women who inject Nyaope. South African government should take a leading role in implementing harm reduction as an SA-do strategy to cap HIV incidence among women who inject Nyaope and to all people who use and inject drugs. More studies on PWID should be conducted to understand the South African drug injecting context better, instead of understanding South African drug injecting context using international research. In conclusion, the Nyaope injecting has brought the field of SCD treatment and HIV prevention together. Those who study HIV prevention cannot do so without taking into consideration women who inject Nyaope. Furthermore, those who provide SUD treatment cannot do without embracing the continuous risk of HIV injection, confronting women who inject Nyaope daily. Lack of needle increases the likelihood to share needle and spread of HIV and other blood-borne infection among the drug-injecting social network. Participants have reported health intervention, economic intervention.
Not Dr. Netangayen. Am I audible enough?
Yes, doctor. Please go ahead.
Okay, this is my presentation outlines, as you can see in the screen, which consists of the introduction, aim, research method, and design, study setting, study population, sampling and sampling size, data collection methods and procedures, data analysis, results, discussion strengths and limitations, recommendations and conclusions. So under the introduction and background, the Ubuntu is defined as an African humanist and philosophical viewpoint, the human situation and how people behave towards one another. The principle helps nurses and midwives understand that another person's humanity is a part of their own. It is determined by the degree of person's relationship with or behave towards other people. And this interpretation of the philosophy is seen as a guaranteeing that nurses and midwives treat patients with the respect to which all human beings are entitled. On continuation, Ubuntu is also includes actions that are clearly beneficial to the community, whether they are as basic as lending a hand to a stranger in need or more intricate ways involving other people. In addition, during their training, student midwives will be exposed to the Ubuntu ideology, which emphasizes humaneness, respect, and dignity in patient care. Furthermore, meeting the needs and expectations of their communities by delivering nursing care and midwifery service while taking into account the cultural values as a belief of communities is a requirement of both professionals and ethical standards for nurses and midwives. So prenatal care, interpartum care, and postnatal care are all examples of midwifery services. Therefore, nursing and Ubuntu are closely related. They both highlight that care is the most important aspect of the nursing profession. However, a nurse can be raised and born into an Ubuntu community where they can develop the values of compassion, dedication, and belonging, all predicted on communitarian philosophy of Ubuntu. This is comparable to how someone can be born into a community that is centered around Ubuntu. So according to a philosophical framework proposed by Ubuntu principles and values, senior and junior nurses can work together in a community. So the aim of the study here is to determine the experience of student midwives regarding the application of Ubuntu principles during provision of midwifery services in Vemba District, Limpopo Province, South Africa. So the research methodology and design here is that the study used both exploratory and descriptive research design to understand the phenomenon of Ubuntu, and also the experience of student midwives in the Vhembe district municipality with regard to the application of Ubuntu. The study setting was conducted in 3 institutions which were purposely selected. These institutions include Chilizini Hospital, Donald Fraser Hospital, and Siloam, where midwifery nursing students were allocated. These institutions are located at Vhembe District, Limpopo Province in South Africa. The study population, the sampling and sampling size, the population was composed of student nurses from Tshwane Nursing Campus and University of Venda, while the sampling, on the other hand, were level 4 midwifery students from Tshwane Nursing Campus and University of Venda, the Department of Advanced Nursing Science, the students who were willing to participate in the study. And the sampling size was composed of 30 participants, of which 10 were midwifery students from University of Venda, while the remaining 20 were from the Tshwane Nursing Campus. The data collection methods and procedures, the researcher developed and used an interview guide which comprised of logical organized list of questions. The interview guide questions were based on the objectives of the study. The researcher introduced herself and immediately made a disclosure of the study, requested the participants' permission to audio record the interviews, which enabled the researcher to ensure that no participant-related information or response were omitted or missed. A tape recorder was used by the researcher to make sure that the information should not be omitted or any information should be given by the interview. Data collection methods continue. Both the information sheet and informed consent form provided relevant information, including a full disclosure concerning the study purpose and the use of its finding. And also the researcher also seek permission as a means to build trust and rapport between the researcher and the participants. Individual semi-structures interview were held at pre-arranged venues at each of the sample healthcare facilities. And these venues were in the scheduled section of the hospital to avoid a disruption of the daily operation of these hospitals. So probing questions were used during the interviews to enable the participants more detailed responses concerning the subject matter at hand, and at the end of each interview session, the researcher thanked the participants for their time and their positive involvement and contribution in the study. All transcriptions were anonymized. The data analysis is the systemic process of organizing, categorizing, and reading collected data to translate or convert such information into usable text and image for developing a framework of the findings. So during this study, the researcher analyzed the data with the aid of the text 8-step in the coding process as recommended by Creswell 2020, and in conjunction with the thematic analysis method. So these are the 8 steps of research that were used. That is, the step number 1 was organizing and preparing the data analysis. Step number 2, reading or looking at all data. Step number 3, coding all the data. Step 4, generating description and of all themes. Step number 5, representing the description and themes. Step 6, developing the themes and sub-themes. While step number 7, comparing the codes, topics, and themes for duplication. And the final one was the recording, and the existing data was also followed. So the results are as follows. So the findings were composed of 2 themes, that is theme 1 and 2. The first theme was about the positive experience about Ubuntu application, while the second theme was about the negative experience about the Ubuntu applications. So according to the results, the positive experience of Ubuntu can be related to acts of goodwill according to good manner, ordinary good manners, and treating patients as being with patient as a human, as a unique being with respect and dignity, without prejudice and discrimination. The participants related their positive experience as a means of application of Ubuntu principles during this study. So the development of this theme were framed by the conventional goal-based theory of moral development. And the first theme is divided into 4 sub-themes, which are the following: the patient support. That's the first one. Both student midwives and few senior midwives are able to display Ubuntu principle during provision of midwifery services, while the participants also revealed that they are supportive and caring and also provided patients with appropriate information. That's the student midwives report, which enabled them to understand their health condition and responded possible as expected. While among the senior midwives, the finding also reveals that some of or few of them supporting patients as the application of Ubuntu. Not all of them are responsible for this patient support. So the teamwork work and collegiality among team workers or among healthcare professionals in midwifery, we have identified that the study revealed that the teamwork is one of the aspects of the student experience, which is positively impacted the provision of midwifery services. And some participants revealed that both midwives and student midwives worked harmoniously with each other, resulting in a quality care provision to patients despite the shortage of staff, hence the application of Ubuntu. And the third theme, which is respect of patients, participants highlighted that respect is one of the values of Ubuntu, as described in the context of respecting patients during the provision of healthcare delivery. The student midwives shared their experience of respect between midwives and the patients. The respect from the senior midwife was given, unfortunately, was given to high-profile patients, while another participant noticed that the respect was provided at the specific unit, which was in ANC antenatal care. The last theme was non-discrimination from the positive experience. So according to respectful maternity care, all patients should be treated as unique beings with respect and dignity, irrespective of their culture, ethnicity, and religion, without discrimination or prejudice. So therefore, no discrimination was reported by the participants at this study. They revealed that there are senior midwives who still displayed Ubuntu principle during provision of healthcare services. They also highlighted that patients are treated equally irrespective of their culture, religion by some of the senior midwives in the units. While the negative experience also comprises of different five sub-themes. So according to Goldberg theory of moral development, the student midwives observed the violation in the application of Ubuntu principle because of fear of consequences of opposing senior midwives and self-interest. In this regard, the participants expressed their view with regard to negative experience regarding the application of Ubuntu. So the negative experience, on the other hand, as I've indicated before, that is comprised of sub-themes. The first theme is doubting of patient by senior midwife, fair versus unfair treatment based on race, disrespect of student midwives, physical abuse of patients, psychological and emotional abuse of patients by senior midwives were revealed as sub-themes. The first sub-theme is the shouting of patients by senior midwives. The participant revealed the opposites. Instead of Ubuntu principle application during provision of care, some senior midwives had shouted at patients by saying hurtful things unnecessarily. Usually it lies to the negative outcomes. This was evidenced by quotes from participants who found constant shouting of patients and calling them using their bed numbers or diagnosis that did not embody Ubuntu. Whereas the second theme, that is fair versus unfair treatment based on race, nationality, the participants reported unfairness regarding care provision among South Africans and Zimbabweans, whereas Indians received a special care versus South Africans. The third theme is disrespect of student midwives by senior midwives, where participants reported that the respect of student midwives is in maternity was senior midwives selling at student midwives in front of the patients or in front of other professionals, which is an example of how they are disrespected and like not treated as a unique being. So this type of attitude led to a negative impact on the student midwives, who develop a low esteem and low self-confidence in their daily activity. And this sub-theme resonates with phase 1 of global theory of moral development of stage 1, which is a stage of the pre-conventional phase, where the student could not act on their moral dilemma because of consequences of being labeled or not getting their signature, as they are still learning. So the issue of disrespect and failure by the student midwife to act differently is a dilemma. It's described by the participants here. While the theme number 4, psychology and emotional abuse of patients, that is, the participant revealed that describe how patients were psychological, emotional abuse through verbal threats. They were told that maternal service will not be provided to them. They were shouted at, humiliated, and embarrassed, irrespective of the different stages of labor and severity of pain. These findings reveals a lack of ubuntu in the maternity wards. While the sub-thing number 5, physical abuse of patients by senior midwives, the participant reported physical abuse of patients by senior midwives in labor wards, claiming that the intention is to save the life of the unborn baby. This was usually done to the primi gravida patients, those who are giving birth for the first time, who were not informed on what to expect in labor. The student midwives witnessed the patient who were pulled and stretched their legs forcefully during delivery, and they view it or regarded it as physical abuse. The shortage of staff as the 6th theme, the participants expressed their view regarding the importance and the availability of human resources to ensure quality maternal service. In their description, they revealed that they are working in an environment that is not conducive because of the shortage of staff. They are providing midwifery service without supervision because of the shortage of staff, which they view it as trial and error learning to save both the life of the mother and the baby. They emphasize the significance of having enough qualified and experienced midwives, skilled midwives, to guarantee high quality midwifery service, to a reduction of burnout and shouting at patients as a result of exertion that violated Ubuntu principle. The theme number 7, poor infrastructure. Participants revealed that they are working in an environment that is not conducive because of poor infrastructures. Curtains are used to divide the beds instead of maintaining privacy. They are also revealed the issue of overcrowding that resulted in lack of confidentiality, dignity, and privacy of patients. This hindered the quality provision of maternal services, Ubuntu principle, and violation of patients' rights. So discussion of the study. So according to the arrangement of themes, the positive experience of Ubuntu application, that is theme 1, the patient support during this experience resulted in higher quality because midwives quality care, because midwives massaged laboring women, which induced contractions and made delivery easier and shortened the stage of labor. Patient support during labor is crucial because it shortened the labor and demonstrated the use of Ubuntu, lowering the need for medical procedures such as cesarean sections and their complications. Effective teamwork created a healthy working atmosphere and enhanced patient safety, all of which were reflected in the successful application of Ubuntu values. Respect for the patients in the labor ward and during prenatal care was another example of how Ubuntu values were positively used. Furthermore, mentees such as student midwives imitate this disregard for the patients, which leads to a persistent culture of disrespect in the midwifery field. The findings also demonstrated that because patients' cultural inclination differed and they were weren't all treated equally. They experienced prejudice, but the following guidelines supported the Ubuntu principles: the Patient Rights Charter, the Maternity Guideline in South Africa, and the Batupele Principle, which states that all persons should be treated without discrimination. While the negative experience about Ubuntu application as the second theme here, it is indicated that participants discussed negative experience they had when applying the Ubuntu principles. Senior midwives starting at patient, treating patients differently based on their race and nationality, treating student midwives disrespectfully, physical, psychological, abusing patients, understaffing, having a subpar facilities were all contributing factors to this negative experience. The results of this study also showed that student midwives look to the professional nurses as their role models because of their senior midwives yelling at patients and imitates as they act as the imitator. So the results show that while Zimbabwean and young patients were treated with respect, certain patients such as those who are high profile and Indian, the results of the investigations also detailed that senior midwives showed to the student midwives who were yelled at while attending patients. The study revealed that verbal abuse and the disdain towards women, commonplace in an effort to save the mother and the unborn child's lives, or of staffing. They also indicated the shortage of staff, which causes professional midwives to become burn out and then unjustly yell at the patients. And this suggests that a staffing deficit may be the cause of potential wrongdoing and ultimately leads to legal action. The strength and limitation of this study, that is, the study strength is its original research strategy, which made it impossible to build it with data that had already been published. Themes were objectively identified, and the interviews were conducted in English, the native language of the individual. And this beneficial because it gave participants the opportunities to express themselves, and the researcher who speaks English fluently. This implies that the researcher paid attention to what was said and how it was spoken, as well as non-verbal cues while interpreting the data. As a result, the participants internalized the subliminal message that were evident in their statements. The potential constraint of a study do not always indicate the potential constraint of study do not always indicate the strength. Instead, these limits identify the disciplinary methodology or practice-related areas that, if overlooked by the researcher, could potentially make the study unsuccessful. The study methodological domain is mostly dominated by poor restrictions, since only fourth-year midwifery students from the Tshwane Nursing Campus and University of Venda Department of Advanced Nursing Science were chosen by the researcher. The study may not be generalizable because of its limited sample size. Furthermore, the absence of managers or supervisor for the study, midwives in the maternity and clinical nurse, may have the same impact in the study. So the recommendations here, based on the findings, the proposed recommendations relate to the Department of Health, the practice of the midwifery professions, as recommendations for future or further research. Recommendation for improvement of midwifery services delivery. Midwifery practice should incorporate the use of Ubuntu ideology during service delivery. All services areas, including prenatal, interpartum, and postnatal, should be deeply ingrained with this Ubuntu application. Using Ubuntu in service delivery will improve unethical behavior that was prevalent in some service units, such as the labor ward, such as link of patient and discrimination and disrespect of the patients. So the study suggests teaching ethical concepts to student midwives while including Ubuntu values, and the curriculums incorporation of Ubuntu values will encourage the growth of positive attitudes, abilities, and application of knowledge. Qualified midwives should also be taught Ubuntu as part of ethics through training and seminars. The study's recommendation for further research, the studies describe student midwives' experience applying Ubuntu in Bembe district using a qualitative methodology. It is advised that future studies employ a quantitative technique in order to allow the generalization of study findings, given the small sample size that are typical of qualitative research. Recommendation for the Department of Health to guarantee that patients and midwives are aware of service level requirements. And the study conclusion suggests that the Department of Health should promenade on Ubuntu principles in all maternity wards. So recommendation for the professional midwives, on the other hand, is that those in charge of professional midwives and those in charge of midwifery delivery are advised in every unit to uphold the Ubuntu values of human respect, equality, cooperation, and compassion in order to have a positive impact on student midwives who are acting as the role of the imitator. The study also suggests that the matrons should make Ubuntu principle a major component of their weekly supervision of certified profession. In conclusion, the main goal of this study was to investigate how student midwives at the public hospital of Bembe district Limpopo understood and applied the Ubuntu idea. Such an interview is crucial from the standpoint of the researcher because it offers a Ghanaian insight from the very people experience form the basis of a deeper comprehension of the dynamic of midwifery in canine and naturalistic setting. The overall results of this study provide a useful reference point features research by other scholars in the fields of medicine, midwifery, and Ubuntu principles. Despite the potential restriction in generalizability mentioned, according to this study, a core goal of midwifery and the provision of healthcare services is the importance of patient care. Thank you.
Thank you, Doctor, for your presentation. If anyone of the audience want to question, please.
The study type is a prospective cross-sectional study. The location is Dr. Anil Kulkarni Eye Hospital, Meerut in Maharashtra. The duration is September to March 2020. The sample size is 60 patients and it is aged from 15 to 75 years. Basically, the meibomian gland dysfunction is a chronic diffuse disease. It is an excessive evaporation of tears, cause of 86% of dry eye cases. So mostly, it is caused by the obstruction or malfunction of the meibomian glands that are in eyelids and are responsible for producing the lipid layer of the tears. And IPL, it is a polychromatic light that is used to thermal pulses to stimulate the meibomian glands to resume its normal activities. So it performs with a 500 nm to 1200 nm light pulses for 20 to 30 minutes. So basically this IPL, that is intense pulse light, is a therapy in improving the symptoms and signs of meibomian gland dysfunction. And it is a very common condition that can lead to dry eye syndrome, and current treatments often provide the limited relief. And this therapy has shown promise in previous studies, and this research seeks to systematically assess its impact on gland function, tear film stability, and the patient-reported symptom over the improvement. So basically, the aim of the study aims to evaluate the improvement in meibomian gland dysfunction patient following intense pulse light treatment. The objective to evaluate this therapy in this patient of MGD and associated dry eye symptoms. The methodology, the study design, it is a prospective study. Participants, 60 patients diagnosed with MGD. The secretion quality, it is more than 2 degrees. And the dry eye symptoms, period September 21 to March 22. Setting, it is Dr. Anil Kulkarni Eye Hospital. we have evaluated the Schommer test and mammography. The IPL device, that is eyelight line review 2.1, the severity assessment, me-check screening device, the response, the categorized good, better, or no change using the OSDI 6 questionnaire. Now, inclusion criteria, the patient complaining dryness, the age is 15 to 75, and the diagnosed patient of MGD with poor quality of the tear secretion. Exclusion, corneal disorder, uncontrolled systemic disease, the patient below and above of this age criteria, pregnancy, and if there is a history of ocular trauma. Now, if you see the result, the male and the female, the percentage, the female percentage is 57% and the male is 43. If you see the graphs showing the severity of dry eye by assessing the Schommer test before and after. So, before and after the IPL treatment. And here we are giving the show the dry eye symptoms severity according to the OSDI dry eye questionnaire on me-check before and after IPL treatment. So basically from 120 eyes shown a mean patient age of 42.46 years with 57% being female. Improvement was noted in 50% of the patient reported good result, 21.66%, that is 13, reporting better result, and 28.33% reporting there is no result actually. So there is a significant improvement in MGD patient were observed with a positive changes in clinical examination and subjective scoring. So significant improvement observed in the MGD secretion quality after IPL treatment. The Schommer test score, that is also improvement. So that is indicating the increased tear production. The mammography revealed there is a positive change in the meibomian gland structure, and the majority of the patient reported improvement in the dry eye symptoms. So the conclusion is the intense pulse light, that is the IPL, it is very safe. It is a non-invasive and effective treatment of MGD-related dry eye disease. So it improves both objective clinical parameters and subjective symptoms without any adverse effect. And the automated eye light software adds case of use and consistent result, and long-term follow-up studies are recommended. So this is the my presentation.
Thank you, Doctor, for your presentation.
Yeah.
Of pseudohyperkalemia, diagnostic diploma in cancer patients with reactive thrombocytosis. So let's come to the introduction. As we all know, hyperkalemia is a life-threatening condition if misdiagnosed or mistreated. Pseudohyperkalemia is falsely elevated serum potassium, and it can lead to overtreatment causing hypokalemia, which itself is a life-threatening condition. Reactive thrombocytosis is a potential but under-recognized cause for the pseudohyperkalemia, and it's important to differentiate pseudohyperkalemia to avoid complications from inadvertent treatment. My study objective is to present 3 cancer patient cases demonstrating pseudohyperkalemia secondary to reactive thrombocytosis. It highlights the clinical implications of misinterpreting laboratory results. So coming to the case scenario, first case is a 29-year-old male who underwent surgery for carcinoma buccal mucosa at our center. After 4 days, he developed a surgical site infection. He was started on antibiotics, which includes cefoperazone and sulbactam combination. On postoperative day 12, he was found to have high serum potassium of 5.5. His other laboratory parameters were hemoglobin of 7.3, total leukocyte count of 15,700, and platelet count was 18,38,000. His renal function test was normal and ECG did not show any sign of hyperkalemia. He was hemodynamically stable with normal systemic examination. He was started on treatment for hyperkalemia like salbutamol nebulization, glucose insulin drip, low potassium diet, and potassium binders. However, hyperkalemia persisted. Considering the possibility of pseudohyperkalemia, whole blood potassium level was advised, which was within normal limits, and further treatment for hyperkalemia was discontinued, and he was discharged in stable condition. Coming to our second case of 72-year-old male diagnosed with carcinoma penis, underwent surgery at our center. He developed a surgical site infection. He was started on piperacillin tazobactam antibiotic. On post-operative day 15, he developed hyperkalemia with serum potassium of 5.5. He also had a history of ischemic heart disease for which he was on ACE inhibitor. It's a cardiac medication named as angiotensin converting enzyme inhibitor. Because of hyperkalemia, ACE inhibitor was stopped as it is a side effect of ACE inhibitor, but hyperkalemia persisted. His CBC showed hemoglobin of 11.1, total leukocyte count of 12,500, and platelet count of 11,18,000. His preoperative lab parameters were within normal limits. ECG was consistent with preoperative ECG and showed no signs of hyperkalemia. He was started on treatment for hyperkalemia due to cardiac comorbidity. His whole blood potassium was advised, which came to be normal, and further treatment for hyperkalemia was stopped, and he also got discharged in stable condition. Another case is 35-year-old male diagnosed with pseudomyxoma peritonei. He underwent cytoreductive surgery, including splenectomy, due to metastasis at our center. He developed hospital-acquired pneumonia and surgical site infection, and his antibiotics included cefupirazine and sulbactam combination. On postoperative day 10, the laboratory informed the critical value of serum potassium 6.4. His other lab parameters were hemoglobin of 9.5, total leukocyte count of 13,970, and platelet count of 8,14,000. The renal function test was normal. Preoperative blood parameters were normal. He was hemodynamically stable and systemic examination was normal. He was asymptomatic and ECG was normal. Due to severe hyperkalemia, he was also started on treatment to lower the serum potassium. Due to reactive thrombocytosis, we suspected pseudohyperkalemia and his whole blood potassium test was advised, which was normal. Hence, the diagnosis of pseudohyperkalemia was proven and further treatment was stopped. And in few days, he also got discharged in stable condition. This is the table which summarizes the important laboratory findings. As we can see, all the three patients had anemia. All three patients had infection, which is seen by this elevated WBC count. All of them had high platelet count, which has caused pseudohyperkalemia. Serum potassium for all the patients were on higher range. However, whole blood potassium was within normal limits and renal function parameters were normal limits. So coming to the discussion, as we know, hyperkalemia is labeled as when serum potassium level is more than 5 milliequivalents per liter, and we can classify it as mild, moderate, and severe. Pseudohyperkalemia is an artificially increased serum potassium concentration that does not correlate with in vivo plasma potassium concentration. Common causes of pseudohyperkalemia include poor technique during collection and pre-analytical processing of blood samples. For example, fist clenching during venipuncture, vigorous mixing of blood sample tubes, in vitro hemolysis, sample exposed to low ambient temperature, etc. Patient conditions that lead to pseudohyperkalemia includes leukocytosis, thrombocytosis, inherited defects in erythrocyte membrane. Again, thrombocytosis can be divided into two groups: primary or essential thrombocytosis, which is due to excessive platelet production as seen in myeloproliferative neoplasm. It is associated with increased risk of thrombosis and bleeding compared to reactive thrombocytosis. And secondary or reactive thrombocytosis, it is seen in acute blood loss, iron deficiency, acute or chronic infection, malignancy, asplenia, or chronic inflammatory diseases. It resolves when the underlying causative condition is addressed. However, reactive thrombocytosis, though it is benign, the underlying cause can be associated with increased risk of adverse outcomes. What is special in our case study is all three patients in our study had multiple risk factors like malignancy. All of them were solid malignancy patients. They underwent surgery which led to intraoperative blood loss causing anemia. All of them had postoperative infection, and one of the patient underwent splenectomy. So while other studies mention that single risk factor causes reactive thrombocytosis and pseudohyperkalemia, in our patient, multiple risk factors were present, which significantly increased the likelihood of reactive thrombocytosis compared to having a single risk factor. One of the patient in our case series needed splenectomy due to metastasis, which is the cause of reactive thrombocytosis, which is similar to the case study in literature by Sanday et al. All our patients were asymptomatic for hyperkalemia, and ECG did not show any signs of hyperkalemia. It is similar to study in Indian Journal of Critical Care Medicine. We advised whole blood potassium testing, and it was normal in all patients, and further treatment to lower serum potassium was discontinued. The short mechanism behind this is platelet release potassium during clotting process, resulting in higher potassium concentration in the serum as compared to plasma. Hence, simultaneous measurement of whole blood potassium, that is when you collect the sample in heparin bulb, will help in diagnosing pseudohyperkalemia. To conclude our case series, it is very important to identify pseudohyperkalemia promptly in patients with reactive thrombocytosis, especially in the setting of malignancy, postoperative status with active infection, and post-splenectomy status. Why? Because it will prevent iatrogenic hypokalemia, which can be life-threatening. And clinicians must have a high index of suspicion when the measured serum potassium is not correlating with baseline readings, or when the laboratory values and ECG are not aligned with the clinical scenario. And if pseudohyperkalemia is suspected, whole blood levels, that is sample collected in heparinized bulb, needs to be measured for correct diagnosis. These are the references for my study. And I would like to thank you for the organizers for giving me this opportunity to present at this conference, International Conference of Global Healthcare and Medicine. Thank you.
This is a comparative exercise between patients from the bypass register and patients from our hospital. So what is this article about? We made an analysis of bypass registry and our patients in our hospital in the University Clinical Hospital in Ribeirão Preto from the São Paulo University. I will make a brief overview of cardiovascular disease as a leading cause of death globally and the importance of diversity in a clinical trial populations. A mention of limited progress in achieving diversity, and a highlighting the significance of the bypass registry in Brazilian cardiac surgery research. Our methods, this is an overview of patients group studied and as a comparison, and a descriptions of data collections methods and aesthetical analysis, and a mention of ethical considerations and approval process. Our results, the key findings, the demographics and clinic findings, the prevalence of comorbidities, our surgical outcomes and complications, and a highlight significant difference before and after surgery. For example, renal and hepatic functions and biochemical indicators. The prevalence of CABG is higher in males. The majority had hypertension, severe coronary lesions, dyslipidemia, and were smokers. The top medications were aspirin, beta blockers, und simvastatin. Common postoperative complications were bleeding, stroke, and acute myocardial infarction after the surgery, and increase of renal dysfunction post-surgery, and elevated levels of liver enzymes post-surgery. The majority had good preoperative renal and hepatic functions. Troponin levels decreased in post-surgery. Vasoactive amino used during the cardiopulmonary bypass. And a small percentage had previous surgeries. And aortic occlusions time from patients with previous surgeries were higher than the others. Types of associated surgeries with the bypass were valve replacement and pacemaker replacement. Our results is the comparison of demographic and clinical data with bypass registry, major causes of death and postoperative outcome is both cohorts. And a comparison of demographic and clinical data with our hospital patients. And similarities in operative and postoperative data, and some difference in operation dates and complications. So the importance of the bypass register as a reference for therapeutic procedures, analysis of difference between patient groups, and speculation on factors contributing for mortality difference, and the importance of both randomized controlled trials for observational studies in research. In our discussion, we talk about the importance of bypass registry for the results in bypass surgery, and a whole as a reference for therapeutic procedures, and potential for improving patient safety and surgical practice. There were differences in the mortality rates. We made an analysis of patients' demographics and comorbidities, and there were notable difference in AMI prevalence and mortality rates. And we had used the bypass for interpretations and post-operative mortality rates in our hospital. We made some medications and mortality speculation, a complexity of preoperative medications analysis, and the prevalence of aspirin usage and implications for mortality. And we also make speculation on factors influencing mortality, cardiac specialty hospitals, and low volume hospitals. There was an impact of hospital volume on mortality, the discussion on the impact of hospital volume on mortality rates, and we made observation from previous studies and on the mortality hospital. We also made a consideration for patient selections in our hospital, in the specialized hospitals. So there is an importance of observational studies for quality control, a whole of observational studies in real-world scenarios, and a value of observational methods in established high external validity. And this is a topic for graded higher in research execution, regardless of method used. So the limitations of our study, including data collection time and sample size, acknowledgement for potential biases and confounding factors, and we emphasize the need for continued research and improvement in data collections. Our key finding was significance of bypass registering representing national KBG data, and similarities and also difference between patients groups, and the implications for patient safety and surgical practice. This study is a call to action for further research and quality improvement efforts. So thank you very much for your patience and for your attention.
Thank you very much, Doctor, for your presentation. And now we welcome to any question from the audience.
Critical care, and we are here to talk a little bit about how we implemented the nursing workload assessment score in an ICU. But first, we need to know what is nursing workload. Basically, nursing workload is the time spent by the nurses, the time that we spend taking care of our patients, either on direct or indirect care, either from autonomous or interdependent functions. And why is it important for us to assess the nursing workload? First, to characterize the work developed by the nursing team, providing visibility for the work that we do, to be able to compare our work with other ICUs so that we can have some benchmarking, and also very important to provide data for nursing research. But the most important factor is to ensure safe staffing, so that we could give management tools to optimize our resources, our nursing resources, to maintain quality and safety of care, and it's a quality indicator of health services. And in Portugal, the reality is that the workload nursing scores are taken into consideration, but are not the only defining factor. In Portugal, we have a regulation defining safe nursing ratios issued by our Portuguese Nursing Board that were transcribed to law in 2019. And also our Ministry of Health recommends the use of a nursing workload assessment score in ICUs even since the early 2000s. So how do we calculate, how do we operationalize our nursing workload assessment? Basically, we use nursing workload scores that exist since the early 1970s to measure time spent on patient care. Each point on the score represents a time spent taking care of our patients, but the early scores were initially based on clinical severity, focus on the work related to diagnose and have some therapeutic interventions on our patients. And then through the time, they eventually evolved to broadly assess the nursing workload beyond just therapeutic or diagnostic interventions, like taking care of families, for instance. And here we have a chart with a few of the nursing scores that were developed since the early 1970s to early 2000s. In our ICU, since we have been established in 1999, in the early years, we had a nursing workload assessment using two different scores, the NAMAS and the Therapeutic Intervention Score System 28. But the team felt that regardless of the patient, the score was almost the same, regardless if the patient was more or less time consuming. And then the question arises if the results reflected the real workload of the nursing team, and there was a question of reliability. And at this moment, we stopped assessing the nursing workload using these scores. But we never stopped in our minds thinking that we should do a nursing workload assessment, but we only had to find a different tool, a better tool to do so. So we turned to science, we turned to evidence-based practice. There were a few scientific research undergoing in the early 2000s, and one we believed that was very important about the nursing activity scores, like we see here, in different countries and different hospital centers. And the nursing activity score, it's a score that evolved from the previous therapeutic intervention score system, 28. This scientific research undergone in 99 ICUs across 15 countries, so quite robust. And it showed that the nursing activity score covered 80.8% of the nursing activities, the time spent by nurses taking care of the patients, versus the 43.3% that happened using the therapeutic intervention score system 28. Mainly because it reflected autonomous nursing activities beyond just therapeutic and diagnostic interventions. Beyond this, the nursing activity score presented to us 2 or 3 more advantages. One, very important, was the broad interpretation that a score could have a similar percentage score, meaning that if a patient scored 80, for example, in the NAS score, the nursing activity score, it meant that the patient required 80% of the time that a nurse had in her shift taking care of that patient. And it was also very important to us that a colleague of us here in Portugal had already made a research showing to us that this score was a reliable and valid instrument to assess the nursing workload in Portuguese ICUs in the Portuguese population. As we can see here, that he published that research. And the third advantage that we have is that in our nursing record software, we already had a tab with the nursing activity scores that we could almost immediately start charting without any new implementation or update needed from the software company that provided that service to us. And that here is the aspect that the chart had in the software that we just needed to start updating, ticking the items that we needed, and immediately we had a score. And in the end, the time spent by the nurses taking care of that patient in that day in minutes. So we decided to start a project to see if the nursing activity score was in fact a better score, a better instrument to assess the nursing workload in the ICU. We started by using the previous nursing score system, which was the T68. That was a score that we already used a few years back, and the team was already, it's easier to score, it's easier to manage, and the team was already trained in doing so. Just had to be remembered, and then it's easier to start this way. And then we upgraded to the nursing activity score, since it was an evolution of the therapeutic intervention score system. So we did this. We started in June to August in 2019, started to train our team to test the score and standardize making some standardization so that all the team did the charting of the score in the same standard fashion. And we started the assessments since September 2019 to February of 2020. And then immediately after, we did the same with the nursing activity score from January and February testing, training, and standardization and from March to June in 2020 started to assess the nursing workload using the nursing activity score. And these are the results that we had. We had a few more patients with the TIS-28 than from the nursing activity score, a few more days assessed from one or the other. But what we see here is that the average score and the average nursing care time almost double. In time, it's beyond the double. We didn't use, obviously, we didn't use the same patients because we couldn't use the same patients, but we see that the type of the patients that we have in our ICU is almost the same cadre of patients. And we almost double the score, and we more than double the time spent by the nurses taking care of the same type of patients. And we decided then to publish a result, so that if you could see the times here, I could explain you that the number of patients that we used in the NAS, it's a little bit smaller than the number of patients that we use scoring the TIS-28, is because if you see the dates here, it was about the time that we were hit with the COVID-19 pandemic, and we had to stop doing the NAS in all the ICUs that we had to expand. We had to expand to 4 ICUs, and we could only do it especially in 2 of those ICUs. We only have data to do the nursing activity scores in 2 of those 4 ICUs. But that provides us with the opportunity to see what was the impact of the COVID-19 patient in our nursing workload. It provides us a very special opportunity. And we found that the time spent by the nurses taking care of the patients, the nursing workload, was not very different if the patient was treated full treatment with ICU full treatment, meaning even mechanical ventilation, or if it was the treatment was sustained at the non-invasive ventilation, meaning that theoretically less degree of severity patient didn't mean that the nursing had to spend less time treating of that patient. Whether it's the patient with more or less severity, the nurses in the ICU needed to spend almost the same time taking care of each of those types of patients. And in the end, we made this chart with these advantages and disadvantages that we saw on the 2 scores in the TIS-28 and the NAS, and nursing activity score. The TIS-28 had some advantages. It's a wider use in ICUs in Portugal. It is, in fact, reliable and easier to use, but it had smaller coverage of the nursing activities. It had an intermediate precision, mainly because it only covered interventions related with therapeutic interventions or diagnostic interventions, and not all the needs of the patient. The NAS was more reliable because it was more comprehensive, almost 80% or beyond 80%, with an increased accuracy because it was not limited to patient clinical needs, but it was more complex and time-consuming to complete the charting, and with greater exposure to subjectivity. That's why we needed a special time with training and standardization between our team. And this provides us, at this point, that we believe the NAS was a better choice to continue the workload assessment in our ICU, and that's what we did since then. We continued to collect data, and here we have a chart that we have data since 2021, 4 years. That's quite a robust set of data at this point. We have 2,300 patients with nursing workload assessed. We have almost 11,000 days of nursing workload assessed. And we can see here an average that every year it's starting to slightly increase. Therefore, if we we get sustain the collection of this data through the time, and we maintain this information through time, we can establish a trend. We can see here in this graph that the NAS average, the nursing workload average, it's raising since 2021, slightly increasing through 2024, and we will continue to do this assessment to see if we have a meaningful trend that means an increase in nursing workload through times. And we can also correlate this data with other important information, other quality indicators in our ICUs, for instance, the pressure ulcer incidence, or even health-related infection rates, to see if any of those are in any means influenced by the nursing workload. And here we have a chart from 2024 divided by quarters, and that we can see if the nursing activity score is in fact important in any of those quality indicators. For the future, we need must keep an eye on what the science is producing and how the nursing workload assessment can help us taking better care of our patients. And ever since the end of our initial research, we see that the science showed us that some other ICUs are starting to use the nursing workload assessment, the NAS, the nursing activity scores, to see if it means a better or worse outcome in intensive care. We started to see some ICUs starting to view the possibility to predict the nursing workload in the next shifts with the nursing workload existed in the previous shifts, like these colleagues here in Norway are doing. We started to see other hospitals here in Portugal starting to use the nursing activity scores also instead of the therapeutic intervention score system, because they also saw that there was more, the nursing activity score was more comprehensive in assessing the nursing workload. And we started to see something very, very important in the regard of the maintaining quality and safety of care. These colleagues here in the Netherlands have shown us that it's more important to focus on the real nursing workload that the patients generate, meaning the time spent by the nurses taking care of the patients, rather than on the number of patients. The nurse has to take care of the ICU, meaning focusing only on the ratio of patients per nurse. It's more important to relate to the nursing workload to calculate, or meaning it's more associated with in-hospital mortality. Thank you for your attention, and we were very pleased to present this to you.
Hi everyone, this is Mr. Muhammad Ali, Surgical Registrar in United Kingdom, West Wales, and it's my pleasure today to present this presentation in the third international webinar on the global health and healthcare and medicine, which is titled under the name of Bridging Distance and Enhancing Care, which is a comprehensive review of telemedicine in surgery. I think this is relevant to the conference because we will discuss, or I will show you what is the updates and innovation in this field, especially it is rapidly evolving field, and it will have a lot of advantage if it is implemented globally over the world, and like what we will see now. So let's start my presentation with objective. First, I will give you a history or the rise of the telemedicine and artificial intelligence, telerobotics, and wearable device. Then I will talk about the benefit like access, cost, satisfaction, and challenges which affect the implementation of telemedicine. And then I would give a hint of the impact of the COVID-19 on the telemedicine, which we can say in one word that it accelerated the adaptation of telemedicine in the field of surgery, and the futures of the telemedicine like artificial intelligence, standards, and global access. So let's do a bit of a small introduction first to and some definitions. Like in the start, I would like to define telemedicine, which refers to the use of telecommunication technology to provide healthcare service remotely in the context of surgery, to involve using digital platforms to conduct pre-operative assessment, post-operative follow-ups, and real-time multi-disciplinary consultation. Telemedicine in surgical care has undergone rapid advancement in the recent years. Telemedicine eliminates the need of patients to travel by enabling remote consultation, progress monitoring for patient and their family, and post-operative care and visits. Historically, telemedicine, which has evolved from early form of telephone consultation to today's use of advanced technologies like video consultation or video conferencing, conference robotics, and artificial intelligence diagnostic, like we will discuss shortly. So methodology about it, let me tell you that this comprehensive review, we managed to publish it with my colleague in a PubMed indexed journal last year. We did our database where we collected papers from database like PubMed, Scopus, and Web of Science. Our keywords were telemedicine, surgery, artificial intelligence, telerobotics, and paper criteria which we included related to the surgical field and which contains its keywords, and we make our best to be reviewed over the last 10 years. So this is a nice diagram about the history of telemedicine, and we can say that telemedicine has started since 1970 thanks to NASA, because NASA initially aiming to support their astronaut via robotic systems in different situations in their career. Then the terminology of telesurgery started in 1991. Which was like a green telepresence system enable remote treatment. This green telepresence system enabled physician to treat remote patients using Metachronic device for the first time. Let me show it to you. This is we consider it as the first surgical robotic, and great telepresence surgeons workstation, like which may like a room in size, or it occupies a whole room, as you can see here. Green telepresence surgeons workstations with hand control. This is the hand control, and they doing the procedure through it. Okay. And beside technical challenges, telesurgery face regularity, regulation, and policy, billing, high cost, liability challenge that complicates its expansion across the United States and the national borders for its good result. That's why you see the difference between years until the first evolved innovation, or let's see, the new era of the telemedicine has started in the new surgery in 2001, when a surgeon named as Lindenberg managed to do the first operation, which named as Lindenberg operation, was a telesurgical operation carried out by a team of French surgeons. As we said, that the boss was named as Lindenberg, that's why it is named after him. This team was located in United States, New York, and they did this operation through Atlantic on a patient in France, Strasbourg in France. And the surgeon was named as Charles Lindenberg. And it was a minimal invasive surgery, laparoscopic cholecystectomy, and it lasted about 45 to 1 hour on a female patient in France via Zeus robotics surgical system designed by computer motion to operate on the patient. Sorry. Also, we cannot say or we cannot say the history without saying the also the impact or the development of the United States Department of the Defense, who aimed to develop the trauma pod system, which allowed combat surgeon to perform critical surgery on injured soldiers from a safe distance without trouble. Okay. We said about this slide, which is the green telepresence system. Now, let's talk about the type and the models of telemedicine. Like you know, pre and post-operative teleconsultations, also telesurgery with robotics, and I think it is the most important one, which is a virtual multidisciplinary meeting, which is a virtual meeting enable various experts from different specialties like surgeons, radiologists, oncologists, pathologists. We can say also radiation therapists to collaborate on complex cases without geographical constraint. You can see this multidisciplinary meeting in various surgical specialties, especially in surgical oncology, because we in surgical oncology depend on the MDT meetings to put a plan for the patient management, especially your patient or cancer patient. Your cancer patient needs not only surgical operation to treat them well, but they need also post-operative or pre-operative chemotherapy or radiation and so on, and also the long follow-up period, which may reach to up to in some cases 5 or 10 years also. So the best way to organize between those experts with geographical constraint or with time constraint also, it is easier to organize between them through the virtual multidisciplinary meeting instead of the personal or physical attendance of those experts to discuss cases of the patient. This is a summary of the usage of telemedicine in surgical care. You see here the pre-operative, and this is what we said, the real-time communication, and also multidisciplinary team, telesurgery, minimizing hospital visit, and we can also conduct new research through telemedicine. You can collect patient data or do surveys through phone with your patient. So it helps also in the new research development, not only in the treatment of the patients. Now, technological infrastructure of the telemedicine. Platforms like MyChart and Doximetry are compared for their usability and integration with electronic health records, while wearable and remote electronic health record remote monitoring device play a key role in improving post-operative outcomes and the patient visit in linking patient data to this electronic health record. Additionally, telemedicine enables the surgery to telemonitor peers remotely without the need for visit. I can say that you have some doctors or expert doctors who can observe another doctors through video call or video conference while they doing operation or procedure. showcasing the potential for enhanced collaboration and improvement surgical outcome. This is the this is my chart, application, and you can see it is recorded here like caloric burned, and they can collect it or send this data directly to the patient electronic records for easier follow-up. And this is Doximity application, also the same idea. You see here they are in a video call or FaceTime, like FaceTime consultation with the doctor here. Now, application in different specialties. Application of telemedicine in orthopedics, cardiovascular, and oncological surgery each present distinct needs and require specialized tools tailored to the unique challenges and procedure with each surgical field. Like if we say orthopedic surgery, which was first described in Finland 25 years ago, where doctors used to communicate and diagnose patients through video conference. Since this data improvement in broadband internet and the communication technology have been increasing, especially for the last few years, till it has increased dramatically during the COVID-19 pandemics. Telemedicine has new role during this time, which increase viral dissemination and the patient contact, and which hinders the patient and physical attendance to the like I said, decrease viral dissemination. However, its main limitation, which was its inability to do proper clinical examination. Also, the same issue during rehabilitation, post-operative rehabilitation. Despite the current sensor advance in usage, helping in the detection of joint movement, therefore, a question. Now we have a question about the reliability of the telemedicine in such a specialty, orthopedic specialty. The same impact of telemedicine also we can see it in cardiac and vascular surgery. For example, patient history and ECG, angiogram, imaging review, same idea like on orthopedic surgery. Tele-ECG, which is remotely monitoring heart rhythm through smartphones and wireless wearable sensors, is another effective example in the diagnosis of various cardiac problems during this era that helps in the management of diseased patients. You know, smartphones are widely available nowadays, and they record your ECG and your also sleep pattern and a lot of stuff, caloric burn it, and how many steps did you do throughout the day, like that. And they may connect it to your electronic health record, so it is easier for your GB to follow up you. One respective study I can tell you about it, which conducted in the MD Anderson Center, which is a famous cancer center in United States, regarding the ability of telemedicine versus or televisit versus the face-to-face visits. And they found there is no difference were detected and evaluated, and they're evaluated in the patient or in different views. The most many developing now we can I would like to say also this is conducted during the pandemic or COVID-19 pandemics. Now, we talked about advantage of telemedicine, but what about the challenges that facing telemedicine? As you can see in front of you, there are many challenges like policy gaps, like we don't have a guidelines, a proper policy or guidelines which control telemedicine, especially you are dealing with patient data, which is related to the confidentiality. And also, we don't have if you don't have a policy which controls the treatment or the deal between the doctors and their patients through this telemedicine. Also, you need to have an infrastructure, and we mean an infrastructure that is high broadband Patient acceptance is another issue. Legal risk, which is related to policy gap and training of the doctors that should be trained in telemedicine, because it is different, totally different from the face-to-face visit, because you can't use your hand in it in clinical examination. And also challenges of artificial integration in the future. But we can say it will be an advantage if it is implemented correctly, artificial intelligence in integration. Because up till now they couldn't integrate the artificial intelligence completely in telemedicine. We are waiting more from them or more updates from them. As I said, that many developing regions lack comprehensive policy on telemedicine, causing uncertainty and inhibiting formal adaptation. Without established guidelines and specialized protocol provide, and the patient are exposed to legal risk, especially concerning liability in surgical consultation. Strong legal framework addressing data privacy, licensing, and reimbursement are necessary to build confidence in telemedicine and surgery. Also, as I said, procedure and examination relying on tactile movement based assessment cannot be replicated virtually. Additionally, surgeons, as I said, also require more training. And also regarding patient acceptance, which is, I think it is the most important besides the policy gap and infrastructure. Because if you have unsatisfied patient, you cannot implement any updates in the healthcare system. And patient acceptance is limited in elderly patient, because they are resistant to any changes, and also patient are, and if the patient have some we can say technological illiteracy, so they cannot deal with the technology, so they will not accept the virtual visits, and still they prefer the face-to-face visit. So what is the advantage of it? And the quality, we said that reduced the readmission and the cost, and the comparable satisfaction and the safety. Also useful on long distance and remote areas. Future direction because we have only 2 minutes to finish. Future directions, artificial intelligence, the integration. As we said, that we still waiting more and more for artificial intelligence to be integrated in this field. Artificial intelligence is fast becoming a part of our daily life, with healthcare being no different. Artificial intelligence has been shown to have a wide range of applications, from diagnostic tool to review of imaging modality. And also global collaboration. We said that we need to our global or across nation global or global policy that facilitates the implementation of telemedicine. And we need also an algorithm or policy that allow how to train doctors, or to know how to deal with the telemedicine. Evidence has suggested that machine learning, deep learning, and artificial intelligence within telemedicine can revolutionize its practice and improve efficiency and cost effectiveness. Also, telemedicine showed its advantage or great advantage in supporting surgical care in low resources or conflict area or zones. I can give you one example, like the Gaza conflict nowadays. Doctors there, they use their WhatsApp group through their smartphones to contact each other and to contact with outside Gaza doctor to help them to manage their patient. Now, conclusion, as we said, telemedicine enhanced surgical care, and we discussed about the challenges which remain, most important in it, which is the policy and the technology challenges, and we need a global standard and a robust framework, so should the telemedicine implemented correctly. And thank you for that.
Thank you very much. And now we welcome Dr. Zibratiski from European Society of Pathology, Russian Federation, who will talk about United Arab Emirates. Thank you very much. And now, on behalf of Scientex conferences, we thank everyone for attending day one of primary and global health care.